The idea of these ground rounds is to give a 30 minutes overview of different topics related to infection control and prevention, antimicrobial stewardship, and hospital epidemiology. These are broad spectrum topics, and probably we are touching from prevention of infection all the way to statistical analysis. And we may want to probably pull the group to see what are the most interesting topics to present in our future ground rounds. And then understand that today has been a slightly change in the schedule that Ruth is going to explain, and allow Ruth to continue and introduce the speaker.
Thank you very much. So yes, we appreciate the opportunity for you to be with us for about 30 minutes on these Wednesdays. Our speaker scheduled for today had a family emergency and needed to switch dates. So we will address simulation in infection control at one of the upcoming grand rounds. I was very appreciative that Dr. Hudson Garrett was available to bring a topic that we know is of tremendous importance as we have looked at our national rates of healthcare-associated infection, that many of them have increased. Some have increased substantially during this pandemic response phase. So as we begin to look at what we hope is a new portion of the pandemic, and as we begin to figure out then and learn from how we have dealt with this viral infection, this will give us the opportunity to remember and I guess dial back some of our activities and refocus on some of the infection prevention issues that we have struggled with for long periods of time. So Dr. Garrett will talk with us today about two of those that have continued to be particularly problematic for us in a variety of settings. So he will be talking with us today about how to reduce some strategies to reduce catheter-associated urinary tract infection and central line-associated bloodstream infection. So Dr. Garrett, we appreciate your continuous work with us through the training center and on a number of other projects, and are appreciative of your time today. So if I can turn it over to you, that will be great.
Awesome. Thanks very much, and good morning or good afternoon to you. I'm on Central Time Zone today. I'm actually on vacation. And so this is really, I think, as Ruth mentioned, a particularly important topic. One that I think transcends most of healthcare, whether we're talking about skilled nursing facilities, acute care, or a variety of outpatient clinics as well. And it's really this concept of catheter-associated infections. And we're going to particularly focus in today on CAUIT and CLABSIs, but keep in mind that there's a broader implication associated with this. The sort of second objective that we're going to hit is really looking at evidence-based strategies to reduce both of these. You'll find that the Agency for Healthcare Research and Quality has focused historically a lot on the inpatient setting, but that is certainly changing. And then lastly, we know that this takes a very team dynamic environment in order to address this. And it's something that we want to do as a sustained effort, not just something that we're going to do as a one-time intervention. So there's a little bit of a background.
Line 1, nurse call, line 1.
And if you could just make sure you mute your lines, we would greatly appreciate it. So there's a little bit of background associated with this. There's an Agency for Healthcare Research and Quality released about 2.5 weeks ago a new guide that was targeting these two types of infections. And they broke it down into what we call Tier 1 and Tier 2 interventions. And think of Tier 1 as the things that are really evidence-based actions that are directly focused on patient care, almost like your bundled approaches. And I know Ruth and I were talking about this even this morning about the importance of bundles, but not just the importance of knowing what they are, but probably more important is sustained interventions and sort of implementing them so that every single patient at every bedside is benefiting from those, right? And that's really about driving consistency in not only our messaging, but also our implementation and frankly, our shared accountability. And Tier 2, which I think are extremely important, are more of those team-based interventions. So things like the comprehensive unit-based safety program, the use of a team steps, multidisciplinary communication tool, right, that are going to allow us to be successful with these programs long-term. Because again, it's not just focusing on one particular thing for a short period of time, but it's really how do we make these part of our overall core practices for infection prevention. Now, there's this concept called Cusp. If you're not familiar with that, right, it stands for Comprehensive Unit Safety Programs. And it was really pioneered out of sort of the Hopkins and Agency for Healthcare Research and Quality. And the whole goal, as the name implies, is to bring safety down to the absolute unit level. We know that infection preventionists play a vital role in reducing infection. Bioanalysis, our providers, our nursing personnel, everybody does. But at the end of the day, the work is done in the unit, right? And where the work is done is where the solutions will most likely be found. And so part of this is saying, first and foremost, we need to understand what safety really means, right? And I think, to Ruth's earlier point, safety to me has changed dramatically over the last 2 years. It used to be patient safety. We would hear all the time, improve patient safety, reduce the incidence to patient safety. And now it's really about healthcare safety, because we know that COVID has taught us some valuable lessons, that it's not just the patients that might be exposed to unsafe conditions. Sort of the second area is one that I particularly like a lot, which is to find the defects, find the faults, find the sort of holes in the armor that allow us to say, wait a minute, that may be what's causing all of these issues, right? And so once we identify the problem, then we have an opportunity and frankly, a responsibility to do something about it. The third one is extremely important, which is you've got to have engagement from the executive team. If you don't have senior leadership involved in this process, championing the effort, walking the walk, if you will, and sitting at the table as a component of saying, whatever obstacles you run into as the senior leader champion or sponsor of this team, I'm here to remove those. Our sort of fourth area is then once we identify the defects, let's not let them happen again. It's almost like if you tell your child, nope, don't go in the street, Johnny, don't go in the street, and they do it 4 or 5 times, we have to then figure out, maybe we should install a barrier, maybe we should install a door lock that's not going to allow them to get out, or is there some other type of intervention that we can learn from them? And last, but certainly not least, is that it is an interprofessional sort of approach. We can't reduce infections associated with CAUITs or CLABSIs if we don't involve the providers, the frontline nurses, perhaps the vascular access team, whoever it may be that's involved in that particular delivery of care. So part of this is really, again, understanding those different components, those tiers, if you will, of how we will do this. And really that tier 1 is all about standardization. How do we make sure that every patient gets the same experience? They use the same kit, the same process, the same insertion process, the same monitoring process. And tier 2 are the sort of higher level strategic things that will allow us to enhance, refine, and really sort of reproduce those practices that we know work in other care settings. So again, our goal is to get these to every single patient. So I wanted to share with you a couple of things up front that are really, I think, applicable to both topics, whether it's CAUITs or CLABSIs, right? And first and foremost, you'll see here is step 0, avoid catheter placement. That makes total sense. If there's not a medical indication and frankly, a medical benefit for the placement of that catheter, then why are we placing it inside the patient? I remember talking to a long-term care nurse one time and she said, I'm so frustrated, right? And I said, well, what are you frustrated with? She said, we have particular providers that order Foleys just because it's more convenient, right? And convenience is not a medical indication. There's some states that do require daily review of line necessity that's then recorded in the medical record. I think that's a good practice, right? Because if we do need it, then yes, let's put it in. But when we put it in, let's ensure that it's correctly placed so that it's clean and it's aseptic, that we're maintaining sterility of that. We then, of course, want to monitor that to make sure that it still needs to be in place. And as soon as it doesn't, we want to get it out of the body. We know that the longer these catheters are left in place, whether in the bloodstream or the urinary bladder, they're going to increase that risk for biofilm formation. Obviously, subsequent infection can also be there in contamination. So part of this with both of them is to make a sort of point to do catheter rounds, right? And we've talked just a second ago about the benefit of doing that daily review of line necessity. Is this a line that is still medically needed for the care of that patient or resident, right? And if not, then let's remove it. Part of this is going to be that frontline nurse, certainly the provider and some of the other ancillary personnel. You may have folks like the pharmacist that might be involved in this particular discussion, especially if the patient starts to grow something so that we know if we need to treat it, or maybe it's not something that we need to treat as well. If we are inserting a line, we also want to make sure the staff are doing it correctly. This is a huge area where we've got lots of variation, not just in insertion and maintenance technique, but frankly, also even in the products that we use with the different types of kits. And if we see something, just sort of like Homeland Security says, say something. Don't wait to intervene later. If you see an observation that could potentially endanger a patient or compromise the care that we're all trying to deliver, then let's stop the procedure. Let's intervene then, and let's allow sort of that opportunity to regroup and then share those findings and those learnings. And so really, if we break this down into the two different topics, CLABSI, your tier 1 interventions are first and foremost, don't place the catheter unless we need to. Makes total sense, right? And if we do need to do that, let's try to use the most well-placed central line possible. And part of that is going to be guided by site selection. So let's just use an example that comes up frequently. Let's say you have a patient that comes into the emergency department and they are a massive trauma and you can't get access on sort of the upper torso. You can't get a subclavian, you can't get an IJ, whatever it may be. There may be some people that say, well, we'll go ahead and place a femoral line. Right? Pretty easy to get, really doesn't require a ton of skill, but very high risk, especially based off the types of flora that are present there. You've got skin folds, you've got hair, you've got a whole bunch of other risk factors there. So that's not our ideal site selection. If we're going to place that line, we can't just place it correctly. We have to also maintain it, right? And so if we're maintaining these lines and checking them daily, doing our dressing changes, assessing that site for potential patency issues or existing signs of infection like streaking or redness, or the patient becomes febrile, this will allow us our best opportunity to intervene before that patient becomes septic. And then last but not least, you'll see this also shared with the CAUIT interventions. Get the line out when it's no longer needed, right? So if it's not needed, let's go ahead and pull it. Our tier 2 interventions are going to focus primarily on things that we can do to not only improve our efforts, but also standardize them and really bring them to light across every single patient care environment we have, right? What are our gaps? Do we have issues with kits? Do we have issues with insertion? Is it particular variations in insertion types? What about data sharing? Are we being transparent and giving the staff actionable data that allow them to say, wait a minute, I didn't realize that was happening. We can fix that, right? And a lot of this is going to be driven by how people insert the catheters. If the catheter is inserted correctly, but it's maintained poorly, right, it becomes a problem. And I can't remember where I saw the statistic, and it may have been CDC, but there was a discussion about most catheter-associated infections, whether it's CAUIT or CLABSI, come from maintenance, right? We see a ton of those where the site becomes contaminated, it's not well maintained. And so it's really about building those competencies and then identifying the issues and then solving them from the ground up. So if you sort of look this and break this down into two, right, these are going to be very interrelated processes. It's not just about, doing the right things in tier 1, but it's really balancing that with an ongoing and parallel effort with our tier 2 observations that say, let's make sure that we're going to be successful with our standardization by having the teams, the dynamics that are necessary to be successful behind that. And that's where tier 2 comes in. And so many facilities concentrate on these bundles or tier 1 interventions, but they fail to realize the importance of those tier 2 things, right? If you don't have the teams, the support infrastructure, the accountability, frankly, the data transparency, the data review, and the ongoing continuous quality improvement, we're never going to reach our target goal, which is 0 infections in this area. Now, one of the other very important points is the clinical indications for these two different types of catheters, right? So this is for a central venous catheter in the ICU, and these are pretty straightforward, right? Nowhere in here do you see anything about convenience, and we see that primarily in my experience with the CAUIT infections versus we do with the central line associated infections. And so part of this is you need to also understand the patient's past medical history. You may, for example, have a patient that's coming in that has really no vessel left, right? And nobody's done what we call vessel preservation studies on these people to identify what are the best possible places. How can we preserve the vasculature in order to protect these extremely vulnerable populations? We see this a ton with dialysis patients that are on hemodialysis, just as an example. They lose that fistula, we can have a very difficult time reestablishing them. There may also be other medications that we want to consult with our clinical pharmacy colleagues, like our vesicants. If we're doing TPN, that might be better served through the use of a larger bore catheter, but also one that's going to be placed into the central vasculature. Now, a big component of this where we can be successful is to also use every tool that we have accessible to us to solve our unique problems, right? Every hospital may be slightly different. Every nursing home may be slightly different, and that's what we would expect. And so a bundle is meant to be customized. For example, let's say that your executive teams, they're on board, they're ready to go, and you know what the issues are, but you can't get anybody in the unit to actually bite on to be a part of the team. Right? That may be where we want to use the Cusp program or the Team Steps program to allow us to move that needle forward so that we can get all of the stakeholders engaged in solving the problem, right? No patient, comes to a hospital or nursing home and says, I want to get an infection. Just that's not the expectation. The expectation is safe and reliable care that's consistently performed. One of the other areas related to CLABSIs in particular is, should I be using things that are going to reduce my sort of risk of infection even further, or are they even necessary? My whole rule of thumb is to do the most basic things first, right? That's always been my practice, because there's no need in doing advanced things unless you have really exhausted all of the more elementary sort of components of infection prevention. One of the things that comes to mind is, when you go to access that line, let's make sure we scrub that device with either alcohol or chlorhexidine as an example before we access what I call the highway, right, to infection, because we're going directly into that line, which is in that patient's blood vessel. Now, there may be certain circumstances where we want to use sort of antimicrobial impregnated hubcaps or pore protectors. We see that, but they have to be used correctly. Now, if you've got, a catheter, for example, that you expect to be in place for longer than 5 days, then you could also consider the use of an impregnated catheter, maybe silver or rifampin or chlorhexidine, right? We see these very commonly commercially available. Then I would note that it's important to use catheters that do have FDA approval, particularly those that have approval to reduce CLABSI infections. That's really going to be a very helpful thing. And you'll typically see the claim called a CRBSI reduction claim as part of that analysis. One of the other things that comes up, particularly in the ICU, is what type of bath should we give the patient? And we know that the cleaner we keep the patient, certainly the reduction for risk is there. But chlorhexidine, especially daily bathing, has been shown in multiple different studies to actually reduce the incidence of these infections related to not just CLABSIs, but also CAUIT infections as well. And so you may be doing this as part of your practice, but it's important that every patient gets these, that's got these indwelling devices. These can be very, very, very helpful in reducing the colony forming units that are present on the patient's skin, right? We know that there's sort of that intrinsic risk that's going to be there from their endogenous flora, and we want to try to reduce that as much as possible. And then if you're doing the insertion itself, the continued best practice is an alcoholic chlorhexidine solution. And most places are using that for patients above the sort of age of 2 months of age, but there are some limited data sets that suggest that you can do aqueous or water-based solution in under 2 months of age if you're using that for CVC insertion. So let's transition as we finish up and talk about CAUIT infections. Now, note that you'll see a lot of the same overlap here, which is particularly helpful as we look for implementation of some of these best practices. Tier 1, no surprise here, right? Don't put the catheter in it unless it's medically necessary. There's also, with CAUITs in particular, alternative types of catheters, like a condom catheter that we can consider using, right? Maybe we don't need that true indwelling catheter. Maybe it's a urinary incontinence issue. Are there better ways that we can care for these patients and residents? How do we insert and maintain those catheters? Do we have the most well-equipped staff that are doing that? Are we monitoring them for compliance with that issue, which we'll talk about here in a second? Removal of that catheter when it's no longer necessary, no surprise there. And then culturing, right? We want to make sure that we're doing this only when needed, right? Just as important as we want to actually sort of standardize our approach to the use of antibiotics so that we're preserving that extremely important arsenal that we have. We don't just want to culture for the heck of it. There needs to be a reason to culture. Is that patient symptomatic? Are they asymptomatic? Are they showing signs of infection? Do they appear to be becoming septic? Right? These are very different than a patient that's sitting there that might have some cells in their urine, but is completely asymptomatic and otherwise completely normal. Now, your tier 2, again, are going to focus on those more quality-driven tools, like doing that gap analysis, making sure we're doing rounding, that we're sharing that data. Do we have people that are well qualified to both insert and maintain that sort of catheter, and then your root cause analysis, as we mentioned before. So just as we saw with the CLABSI tiered interventions, here you can see that outlined as both tier 1 and tier 2. Again, not a ton of huge changes here, with some small additions like our urine culture stewardship and also other alternative types of cultures, of urinary catheters. Now, part of this too, that you'll see consistently across the board in this new Agency for Healthcare Research and Quality sort of guide is the importance of teamwork, sharing data, frontline leadership, and frankly, empowering and expecting the frontline teams to really be the drivers of the solutions. Where the care is provided is, again, where the solutions will be needed, right? And most likely those solutions can be driven from the front lines all the way up into the executive suite so that we do that. Now, we also, just like with CLABSIs, want to make sure that we're only using these indwelling urinary catheters for specific reasons, right? Where there's medical need and necessity to do that. Again, it should not be a point of convenience. So maybe I've got an incontinent patient with a massive wound tear, or they're on a wound vac as an example because they've got a wound, right? That may be an example. Or even with hospice patients, there may be more of a comfort care intervention there where we're not necessarily worried about long-term impacts of the catheter, but we want to make that patient comfortable during their last moments of life. And certainly if we're measuring sort of input and output, this is going to be an important element as well. I know that one of the previous grand rounds, and Ruth, you can correct me, but I believe it was about 2 or 3 weeks ago, was sort of looking at bacteriurias. And so here again is a great reminder to that section. The guide that ARC put out talks about recognizing those true infections, right? Is this truly a patient that is febrile? What is their normal baseline mentation? Is their frequency or their duration of their urination changing? Are they having pain, right? That would make sense. Did they recently have a catheter placed or removed? These are all elements that we have to look at as part of that broader picture and approach to assessing that patient for potential risk, right? Not every patient is going to present the same way. Now, on the flip side of this, we certainly want to be aggressive in monitoring for signs of sepsis. We see this particularly in long-term care facilities where the resourcing is different, right? You've got a larger patient load and the risk for sepsis is certainly pretty high, but that's the same in ICUs. And so it's really a shared accountability of good clinical assessment skills. And if you're a frontline nurse or have frontline nurses that you're working with, when they call the provider, paint the picture, right? Make sure that the provider on the other end of the phone truly experiences exactly what you're seeing so that they can make the best possible decision for the care of that patient. But needless to say, there are some common success factors, things that if we do all the time, consistently and across the board, we will see better success. We'll see long-term success. And frankly, our patients will benefit from some of these evidence-based practices, right? A lot of this is to improve our own comfort with insertion and maintenance and really looking and assessing for signs of potential issues, right? Maybe there's some streaking there, or maybe we've got blood in the Foley as an example. But a lot of that goes back to the staff, right? If you have a very well-educated staff that is highly competent in their skill, then it's a different ballgame than maybe you have a lot of new grads or you have nurses that are coming in as travelers that don't understand your environment. And so we want to not only train, but we also want to assess for competency. Right? Part of this is to really look at other interventions that will help us be more successful. Core things like washing our hands, using PPE appropriately, making sure that we speak up if we see something, and really using data and as much information as we can pull from the electronic health record to guide our decisions. Right? Think about it like your credit score. You don't want to make a decision about, are you going to purchase a home or purchase a car if you don't know your credit score? We want to know our infection rates, but more importantly, we want to know why our infection rates are what they are. Are there risk factors that we can directly target? Is there feedback that we can give to the staff that will make them more accountable, that will make them more empowered for reduction of risk with these catheters, right? And it's all about that overall team and sort of evaluating hazard recognition. Now, just like anybody appreciates, we want to be transparent. We want to be doing things in real time. Think about that sort of performance review where you get it in December of the end of the year and your boss says, well, Hudson, on February 2nd, you did this and it really wasn't really good, right? And you're thinking to yourself, why didn't you tell me then? Why didn't you allow me to have actionable information or intelligence to act and change my ways then. And the same is true here. If staff are finding out about it 2 months later, they have no ability to go back and change that outcome for that patient. But if you have a real-time laboratory notification when you do actually see an infection and the provider concurs with that, then you as an infection preventionist, a frontline nurse, a manager, a clinical nurse specialist, whoever it may be, can instantly act. And we still have the power and the ability to change that responsibility there, right? And these indwelling urinary catheters, or IUCs, right? Understanding utilization and figuring out, were those all indicated? Was there sort of feedback that we should be giving to providers? You know, if you, for example, told somebody, well, you're the top prescriber for this, or you're the top inserter of Foley catheters, or you're the top this, without giving any context, without understanding the overall denominator, without looking at the medical indications, it doesn't help us actually change practice, right? And so giving feedback to the staff is one part, but teaching them how to use it to change, right, and to also adapt and overcome is really a bigger part. And a lot of this goes back to staff onboarding, right? And staff onboarding has not just got to be a compliance checkbox activity, but it's really got to be specific to their role. Is this somebody, for example, that's going to be a frontline nurse that's going to be responsible for insertion of these catheters? Is this a provider, maybe a physician or nurse practitioner or PA, that is going to be responsible for ordering it, but not physically placing the line? Right. So the responsibility of competency relies with the people that do the work, but also with the managers that supervise them. And so part of this is going to certainly be based on our procedures and policies at our institution, but also what are the evidence-based guidelines telling us to do, right? And then from that, we actually assess and measure competency from that. And partly, as we conclude, is assessing skill sets. Nobody likes to do this, right? It's uncomfortable, it's time consuming, but there are ways that we can do this, whether in a simulation environment, which I know that Ruth had mentioned that we're going to have a future presenter on that, which I'm looking forward to, but it could also be observing patient care, right? And there's really probably a need for both. Certainly, we don't want to do things that would ever put a real patient in jeopardy, but there are some things that we have to do with patients so we can learn and observe. And having good preceptors and sort of trainers in the field is invaluable, especially people that are willing to teach, right? We in healthcare, unfortunately, eat our own on a daily basis. Having somebody that's a great teacher, a mentor, and a coach is an invaluable experience. That's one of the wonderful things about Dr. Carrico. I've been fortunate enough to be mentored and coached by her for years. And it's an invaluable experience to have somebody like that. Each person in the clinical environment needs that type of coach in order to really do this. And this is somebody who can share in that accountability, but also draw out the very best in the clinicians at the bedside. So as we conclude and see what questions you have, remember that we're only talking today about devices in the terms of Foley catheters and particularly central venous catheters. But there's other devices that we use, NG tubes, feeding tubes, all kinds of other indwelling catheters that do provide medical utility for sure, but we need to look critically at the sort of functionality of these and the medical necessity. Let's get away from just educating and training and all the money spent there and do more role-specific competency so that we can drive best practices and really assess for transfer of knowledge, right? Transfer and applicability of knowledge. You can teach most people things, but can they apply it in a clinical setting? That's a completely different ballgame. And a lot of this is going to be rooted back in our ability to do continuous quality improvement, to invest not only in our processes and our people, but also really look at the broader picture of the core interventions for infection prevention and control. So with that, Dr. Carrico, I'll stop and see what questions we have from the group. And also, I'm sure you've got some comments you'd like to interject as well.
Sure, I'd love to get comments back from the group. And so as we wait for those, or if somebody wants to comment, you can unmute and deliver your comment or question personally, or if you'd rather put it in the chat, either is fine. But while we wait for some of that, as I've been talking with infection preventionists and others, around the state and beyond, about why are we in a situation where we have seen such an increase in healthcare associated infection during the time of our COVID response. And it's almost uniformly that I've heard that, we have implemented a lot of standardization as part of our COVID response. But what we thought we had in place for standardization with many of the other bundle elements, just as you have mentioned, was simply not there. So it's changing, number one, the nature of the infection preventionist practice. One is trying to find where they might have a chokehold on either information or empowering or whatever, but it's really pushing out so individuals can act. But secondly, to ensure that the workforce knows this information. And so I was interested, I saw in one of the slides that you talked about having personnel that are out doing the reassessment, reinforce, retrain, and that whole notion of bringing that level of process and practice evaluation to the ground level. And so this will change how IPs approach what we do, because we'll be much more focused on how are we doing in terms of process adherence and making that some of the data that we look at. But what are some suggestions that you have on how we can get staff to accept that empowerment, or how can we promote that empowerment, and maybe some ideas about that reinforce and retrain and that ongoing and real-time assessment of performance?
So, I think part of it goes back to the value of leadership and engagement, right? Without leadership engagement, you're not going to accomplish any of this. And for the staff to accept it, we need to create a culture of safety, right? Not safety just with the patient and the way we deliver care, but really that it's safe to speak up, that it's safe to point out an issue, that it's safe to bring data to the forefront, frontline clinicians, as you mentioned. And in a lot of institutions, we don't have that. It becomes more of a punitive discussion where they think they're getting in trouble. And partly, I think that's, it's a 50-50 shared responsibility, right? Some part of it is really the culture of the organization, but the other part is we don't necessarily teach clinicians how to be coaches. And I'd welcome Dr. Ramirez's input on this as a physician too, but, I know, Ruth, you and I really value coaching. And we've talked about this for many years, but not everybody gets that. And it can sometimes be uncomfortable. And I think part of this too is to teach people at the front lines that coaching is great, and that the people that are doing the coaching need to know how to do it successfully, so that, like you said, the staff are willing to accept it and willing to be a part of it. Because there's a big difference between coming down from the quality department or the infection preventionist and you're telling them, versus asking them to be a part of the solution and working with them towards that shared goal. I just don't ever believe anybody comes to work and says, I want to harm a patient. We just don't see that, thank God. But we know that people are desperately, especially during this very difficult 2 years, they're desperately trying to find solutions. And so if we go to them with proposed solutions and say, I'm going to partner with you, I think is the key term, then we get a better outcome.
Good. I see Dr. Wild has a CAUIT question. She asks, what strategies have been successful at improving urine culture diagnostic stewardship? The momentum from a positive urine culture leads to a lot of unnecessary downstream antibiotic prescribing.
I think that's an excellent question. There is a checklist that CDC has, and there's also one that ARC has released, which I'll make available. So I'll send those to Dave so that he can post those as handouts. I mean, part of this is going to be primarily driven by the algorithm in the electronic health record, right? Very similar to what we do with antibiotic prescribing, where we're asking the clinician questions. We're asking them to justify not only the diagnosis, the appropriateness of that antibiotic. And that's really one of the big things that ARC encourages. And I think the other, to Dr. Wild's question, is really making sure that we are able to educate the people that would be ordering these. I know Dr. Ramirez at a previous Grand Rounds talked about the importance of that as well. And that's such a critical element to not only understand the pathophysiology and really what is going to contribute to patient harm versus just carrying some organism where this patient is completely asymptomatic. So I would say start with sort of an algorithm and then staff education and provider education. I think that's going to be your two biggest bangs for your buck. That'll give you more of an ROI and that return on investment.
I think that was like Dr. Ramirez mentioned, when you're looking for tuberculosis and you have a chest x-ray, usually put, what you're looking for. Well, the same thing for some of the cultures where if you make a wrong decision, then you have set up the pathway for treatment, and any treatment would be inappropriate because it is unnecessary. So how do you begin to get people thinking? So again, building in that, what are standardizations of approaches so that you can set up then that decision-making process that will can conceivably stop that downward spiral. And then one said they've used a biomarker to help determine true infection in patients who are colonized. Positive culture means likely no true infection. So using that, the biomarkers. I think, Melissa, you've got particular experience in the use of that in pediatric patients as well.
And I mean, part of this too is, as we talk about in bundles, is using as much data as you have available to make the bigger clinical picture. It's almost like when we're trying to form that differential diagnosis, we're looking at all of the different elements of data that we have before us and trying to sort of cipher that down to, well, it's most likely this, it could be this, what is really going to be the biggest patient harm. And I think the more tools that we can use to say, yes, this is an infection, this is related to the catheter, we do need to treat it, and our confidence level goes up, then our sort of overreach with antibiotics is going to go down because we're being more vigilant in our approach, but also telling staff, hey, I'm glad you brought this to my attention, but this is the reason this is not an infection. And let me share with you that we don't have that closed loop feedback, especially with many providers back to the frontline clinicians that might have asserted that, hey, this is a potential risk with the patient that I'm observing. So sharing with them the thought process, I think, is also a great learning.
Do we have other questions? I think some of these last comments are really going to show the value of having a project that Dr. Wild will be leading, where really looking at antimicrobial stewardship and working with different facilities to see where they are in their own program development, getting and opening up options to have like office hours so people can ask real-time, questions about real-time issues, and then being able to, have that additional feedback and insight and sometimes support for, what may be a correct approach, but may not be what is popular or routine done in individual facilities. So one of the benefits that we hope everyone receives from having this training center will be these types of broad program opportunities and interventions and collaborations that are going to help us figure out what post-COVID healthcare associated infection is going to mean and prevention is going to mean to all of us in all settings. Any last question, Dr. Mears?
Yeah, one question. In the management of the patient with a long-term urinary tract, the literature is divided into the patient has a Foley catheter, and the Foley catheter is going to remain because the patient is not able to, for whatever reason, the patient needs a catheter. And some people say, well, every 30 days, change the Foley. And others say the Foley should be in place, and as long as the urine flow through the catheter, don't change the catheter. And it has been for and again, this is always a discussion. What would be your reading of the literature in this area? What recommendation? Should Foley catheter be, because the patient is in a long-term care, has a Foley, needs to have a Foley, and in some long-term cares, every 30 days they change the catheter. In others, the catheter remains as long as the catheter is not obstructed.
I mean, I think it's a good point. I mean, our first rule would be, does that patient truly need that catheter for that extended period of time? Or are there other interventions like, briefs or a condom catheter or something? I think that's first and foremost. But I would agree with you, Dr. Ramirez. It's so conflicting in the literature. I mean, part of me says, okay, if I leave the catheter in place, and this is really for CAUITs or CLABSIs, that the biofilm should theoretically stay in place. It's not going to be dislodged. It's not going to enter the bloodstream because we're not doing any manual manipulation. And we've also seen this with the literature with CLABSI infections, when we've done over-the-wire exchanges, where we've gone in and exchanged that catheter over a wire and sort of dislodged that biofilm. But I think in CAUITs in particular, it makes sense in a way to leave the catheter in place if it's still functional. There's no signs of infection. The patient doesn't exhibit any signs of infection. There's probably more risk in my mind to changing the catheter, especially if you have clinicians at the facility that are not the most well skilled at inserting them and maintaining them. And that's probably going to be a higher risk just due to the patient volume in the skilled nursing facilities. Not saying that that's always the case, but in an ICU, you're more likely to have that more rigorous assessment of those lines because you have the staff to do that, and the acuity of the patient is different. So I would probably tend to lean towards that side of the fence.
It's interesting because these have been also my recommendations.
Right.
It's good to see that yes. And I seen, as you alluded, patients that after changing the Foley, after 30 days, 40 days, then all of a sudden the patient develop fevers.
Exactly.
To damage the mucosa. Yes. Then my approach is always, as long as the catheter is working, even though I know that it's controversial, but
Sure.
yes, the biofilm is there. Don't touch it. Don't disrupt it. Just leave it alone.
Well,
I think it also is a reminder, teach your personnel, like those that are emptying that drainage bag. That technique is important on emptying that drainage bag, and perineal care still is general personal hygiene is still important. And then reminding people that those catheters there is that big piece of red tape for a reason that connects the catheter to the drainage bag. That means don't take it apart. So don't think that we can increase the life of that indwelling urinary catheter by periodically instilling something in the bladder or, irrigating that catheter. That those systems are designed to be closed and leave them alone. So making sure that, you're minimizing pulling and tugging and movement of that catheter, and poor technique in emptying, like no shared emptying containers, going patient to patient to patient, and getting those very basics, and then leave things alone.
Right. And I think to Dr. Ramirez's point, just a little funny joke as we close out is that my grandmother taught me many things in life, but one of the most important lessons was if it's not broken, don't fix it. And so, citing my grandmother's words, I think, if the catheter is still patent, it's still functional, the patient is asymptomatic, everything is going well, why in the world would we want to potentially disrupt that? So in the words of my late grandmother, as a scientific source, I think that's what I'll stick with as well.
Well, thank you very much. Thank you for those in attendance. And we will be reaching out to you to request information back from you. We want to make sure that we're able to provide you with the information that comes out from the training center. So we may be reaching out to you, asking your permission to be able to send you information, because we don't want to junk up email boxes without anybody's knowledge, with newsletters or other information that they may feel is not relevant to them. So please be on the lookout then for email from us asking for your permission to provide you additional information, both the grand rounds information and what is happening with the training center. So we thank you very much, and we will see you back next Wednesday. And I think next Wednesday, the topic will be Sentinel events. And how we approach Sentinel event recognition and reporting. So have a good rest of the day. Thank you.
Thank you.